Good evening, everyone. I hope everybody had a great holiday, as weird as everything has been. But I do hope and pray that you all were safe and were able to spend some quality time with your immediate family and was able to connect in some form in a safe fashion. So today is January 10th, and I'm happy to rejoin you after a few weeks hiatus for our town hall. Again, I would like to thank our sponsors, the Lupus Foundation of America, Georgia chapter with Terry Iman, the Georgia Council for Lupus Education and Awareness, and the Georgians Organized Against Lupus Research Project at Emory. Please read the disclaimer. You shouldn't take any of this information to be direct advice to you specifically. You should always run this by your physician and healthcare team. So globally, there is greater than 88.5 million cases total of infections and 1.9 million deaths. So that's total over the entire time of the pandemic. 45% of the deaths are in the US, which comprises 19.5%, by far the highest. Brazil, 7.9%, India, 10.4%, and Mexico, 6.8%. But it just reminds you of this stark contrast between the US and the rest of the world in terms of the burden. The US itself has greater than 2.1 million cases and 274,000 deaths over this entire pandemic. And in terms of number of cases during this entire time, India is number 2 and Brazil is number 3. So the numbers I just gave you were cumulative or total numbers over the entire pandemic. Here is a hotspot map of this past week for new cases. So where are the new cases popping up in terms of average daily cases per 100,000 people in this past week? And as I told you, I think last time, certain sites like the New York Times here had to put in a different color code just because things were going higher than levels seen before, and they have this like dark magenta color to represent an even higher level than that which was the highest before that, which was the red. So you see that the United States remains in a hot spot in the highest degree, along with some areas in Europe. And then you see the rest of Central and South America remains very active in terms of new infections. Eastern Europe going into Russia, and then down here in South Africa, Namibia, and Zambia, there's been a large outbreak. Here, if again, this is new cases over time since the beginning of the pandemic. And if you just follow the pink line, which is the United States, you see that we went up very much. And then over actually I'm sorry, this isn't from the start of the pandemic. This is from September, so forgive me. But here, the United States from September, it's been steadily increasing. And then during this winter time, it's really gone up a lot. You've heard, remember the months early on when Europe was the first area to reignite again, if you will, and they were going up very much higher than the United States and the rest of the world, here in the blue. And then since the start of winter, they've gotten things under better control, and that's because they instituted very severe lockdown measures in many of the countries, which would be very difficult to do across the entire United States, given the climates and other issues. So Europe has gotten better, but the United Kingdom, which is really a separate entity, even if you consider things beyond Brexit and finances and all of that. But separate to the rest of Europe, England has really started to spike a lot, and we'll talk about that new variant that they're seeing in the United Kingdom. But this just really puts into context how much they've really gone up in terms of number of cases, surpassing the United States. So in terms of some news from around the world, since last time we spoke, we'll talk again, as I said, about these new variants of the virus, but they have been identified and they've been associated with an increase in transmissibility. Vaccine by the Chinese company Sinovac Biotech is reported to be pretty effective. 78% is a good number, and we would have accepted that before the Pfizer and Moderna vaccines have had higher efficacy rates. But it's great that more and more companies are developing these things. We need lots of options. We clearly don't have enough out there. And so whatever country can come up with more options for them and the other parts of the world, this is great. Immunity to COVID-19 is thankfully seems to be in general a lot longer than longer in terms of what people had feared, what was going to be sort of short immunity. So it seems to last at least 8 months after infection in most people, and it could last much longer. And it probably is a major reason why you don't hear much about reinfection. But I will remind everybody up front that this is great news, but it still does not mean once you get COVID, you're good to go and you don't need to mask, and same thing for the vaccine for that matter. But it is very reassuring and hopeful in the sense that early data shows that immunity is lasting more than a few months. So this is, again, a hotspot map of the US. So hotspot meaning new cases in the past week. And you can see that pretty much the entire country is pretty hot. Remember, in the beginning, it was isolated to California and the Northwest and large parts of the Southeast. It was shifting towards the Midwest, and especially the upper Midwest after the Sturgis motorcycle rally. And then the last time we had spoke, it really centered, in addition to California, Arizona, and beginning of some parts of the Northeast, Tennessee had the highest rate in all the world. But I reminded everybody that these are just political borders, and they certainly aren't going to keep the virus from spreading, and it certainly has done that. So as you can see, it's gone throughout most regions of the country, and it's certainly back with a vengeance to the Southeast. This is for the entire US still, and upper left here, you see the trends in terms of new reported cases. And you can see we're in uncharted territories. We keep going higher and higher to the point where we've never been before. And it's hard to keep saying this every single time. And I know there's a certain amount of fatigue associated with this in terms of understanding it and hearing it, but it needs to be repeated. And with the new deaths, with the new infections will come deaths, and you see the increase in deaths here. So the cases have risen over the past 2 weeks, 34%, and the deaths 43%. And it's no surprise that you see the hospitalization rates going extremely high. And you're hearing about all what's going on in certain other states like California. Georgia is this blue teal color here, and we were at some of the lowest rates in the country relative to everyone else earlier in the winter time, but you see now that we are certainly amongst the higher rates for different states. Areas like New York and California are still higher, and you can see the real outlier of Arizona, the extremely high rates of new cases there. But we're certainly not in our comfort zone anymore, and we've rejoined the pack, unfortunately, in Georgia in terms of lots of new cases. We'll talk about that shortly. Along those lines, we talked about how the Southeast was really the hot spot early in the pandemic, and then it moved away from us, with Georgia being some of the lowest rates, and now it's really come back to the point where the rates really dwarf the past spikes that we've had. Graphically on the right, you can see that the South is in the darker color here, and we're at much higher rates than we had experienced before. The rates in the South are rising very quickly. There were 82,074 new cases this past week, about 20,000 more than the Midwest's peak in November. In Alabama, 1 in every 4 tests in the past 2 weeks were positive. And it's no surprise that they have some of the most strained hospital systems in the country. 41% of the nation's COVID patients are being treated in the South. So we hear a lot about California and the Northeast, but we're right in the middle of some of the biggest hotspots areas in the country, if not the world. And for those that continue to think that this is no different from the flu, I don't know what other information they need. Certainly have not heard as much about those types of comments now. And to further underscore that, yes, the flu certainly has killed a lot of people, unfortunately, in the past, and every year it continues to do so. But you don't hear about the flu being in the top causes of death in any year. And here, this past year, with the pandemic not even starting exactly on January 1st, in terms of its full known effect, COVID-19 was the 3rd leading cause of death in the US this past year. 1 out of 990 Americans have died from COVID, and 1 out of 200 of those were 65 and older. That's the group that really bears the brunt of this entire pandemic. Just an additional number to add to that, about 1 in 1,500 people who are greater than 25 years old is currently in the hospital with COVID-19 infection in this country. US recorded more than 4,000 COVID deaths on January 7th. And we've certainly heard about the beds running out in especially the ICUs in LA County. Well, they're also running out of oxygen because of the demand. The Federal Health and Human Services, or the medical portion of the federal government, urged states to begin offering vaccine to a broader range of people, seniors and other high-risk groups, in order to speed up pace of immunizations and to prevent doses from going to waste. And thankfully, there have been very few reports of severe allergic reactions to vaccines. For the Pfizer vaccine, out of 1.9 million people that have received it to date, there have been documented 21 severe allergic reactions, of which all but 1 have fully recovered. So yes, 21 severe allergic reactions is not good, but put into the context of 1.9 million people, it's extremely rare and quite favorable to a lot of other medications and situations. This is a hotspot map of Georgia, of new states, average daily new cases per 100,000 in the past week. And you can see it's pretty much throughout most of the state. You have really high numbers or high rates. You can see the increase in the new cases over time. And again, just like the rest of the US, we're in uncharted territory. We're in extremely high numbers of new cases. And similarly, we're starting to see the death rates going up. And all this, in terms of what we are pretty sure will happen, is that the full effects of Christmas and New Year's is not even being felt yet. It will be over the next 2, 3, 4 weeks. So we actually have a lot more hurt to go, is the common saying that you're hearing and reading about, and unfortunately that's the case. These are the current hospitalizations by day in Georgia, and you can see we're extremely high compared to the previous peak that we've had. And all this is not a surprise when you put things together, that at our last town hall, according to this metric at COVID Act now, we were in the red. Now we're at the highest magenta group category in terms of COVID risk level, putting together all of these different parameters, a very high daily new case rate with a high infection rate that is also reflected in the test positivity rate, that our ICU as a state is at over 90% capacity, and in some areas over 100% capacity. I've summarized some findings from the recent White House Corona Task Force report as it relates to Georgia. And Georgia has the ninth highest state. It's the ninth highest state for new infections. It's the eighth highest in terms of the test positivity rate. In Georgia, Gwinnett, Fulton, and Cobb counties represent nearly a quarter of new cases in Georgia. 32 out of 100 hospital beds are occupied with COVID patients. And as we're all finding out and hearing about, the vaccine rollout is very slow. It is either last or next to last in the country. So here is the doses distributed across the US per CDC numbers, about 21.5 million, but we've only administered or actually given under 6 million of those doses. So only 27.6% of doses that have been distributed have been administered. So there's a big call to get things moving, and it's a very complex issue. It's not quick. I can't quickly say it's just this or that, but clearly we're failing. And I think one of the big conclusions is that this is unfortunately a reflection of many years of neglect of the public health infrastructure and the system, very poor funding and attention paid to that. And now we're trying to catch up very quickly. And people are certainly trying to do that. The number of administrations of the doses have been going up very much. But we need to use these doses that are out there. And it's really made a call for some people to consider whether we should just start opening up some of these doses for other groups, as I've just mentioned. And some of you have been hearing and reading about the possibility of just giving it to as many people as possible for their first dose without making sure that you have enough for people's second dose. Because a certain number of what's being held back is just that. For every one of these doses that we're giving here at the bottom, all the vaccines that we have to date, Moderna and Pfizer, require 2 doses. So a lot of places are making sure that they have the second dose in hand and available when these people come back in 2 or 3 weeks. It doesn't account for all of this difference, that we still need to administer more and more, but the the Biden administration has been talking about when they fully come into power, possibly just releasing all of the first doses. And that would mean that at some point, people may not be able to get the second dose at exactly the time that we are doing it now, 2 or 3 weeks, depending on which vaccine you get. And I'm hearing a lot of different things here. The FDA came out with a statement that we should not change the dosing regimen. There are other people that I've seen and read about that are experts in the field that say there shouldn't be any major harm in lengthening the time between doses. So I'm not really sure what's right, and we'll have to see how things shape out over time. But what's clear is that we don't have as many people vaccinated as we should have at this point, or want to have, or need to have. And certainly in Georgia, per this story and other citations, we're the very last among all states in percent of vaccines administered so far. In the US, throughout the US, about 31.7% of the shots of available vaccine have been used. In Georgia, we're dead last in the country at 21.5% of the shots that are available in this state have been given out. So I'm just intermixing some of the questions that we've received along the way, and I'll get to most of them at the end. But here there was a question about, why do you feel so many in the health field are refusing to take the vaccine? Well, I didn't have time to research other surveys, but there was a survey that we had done just this past week at Grady of both physicians and other patient-facing staff. These are people that directly interface on a clinical level with patients. So we're talking about physicians, nurse practitioners, physician assistants, and so forth. So you can see we had 479 of these patient-facing positions, clinical healthcare workers, and you can see the characteristics here of female, male, the age breakdown. 2/3 were white, 11% Black, 14% Asian, 5% Latino. The vast majority, 92.5%, have already received their first dose, mostly through Emory, because a lot of the physicians that work at Grady are Emory faculty. The others are Morehouse. And among the 32 who have not yet received the vaccine, some of them, or most of them, had COVID. There's a decent number that had some fear or personal preference, and they were not eligible due to some medical condition. But the vast majority have gotten it already, and there's some that may eventually get it. Now, the non-patient facing people, these are people who interact with patients, but not so much more than a very brief period of time, and not clinically. So we're talking administrative staff and research staff. You can see the demographic breakdown here, and only 20.4% have received their first dose. Among these individuals, many of them just have not been eligible or offered the vaccine yet. And that's because we're rolling it out in our healthcare system per the CDC guidelines and the state guidelines, and that is, we're doing it to healthcare providers first, and not necessarily people who are working in hospitals who are not directly interacting clinically with patients. So that's the vast majority, that they just have not been given the opportunity. The fear and personal preference were only 15%. And so one of the take-home messages that I've heard from this is the good message that, or interpretation of this data anyway, that of people who are healthcare workers, many of them, or the vast majority, are getting vaccinated or have been vaccinated. The ones that are working in the healthcare system, the vast majority want to get it. They just have not, many of them have not had the opportunity to get it yet. And it's just a small percentage of them who are not getting it for fear or personal preference. There was a survey that the Lupus Research Alliance did of people with lupus, and they report that the majority of people with lupus say that they would take the vaccine. It's not published in any scientific journal that I'm aware of, and I think they blast it out in terms of their listserv and the website and things like that. So there's going to be some bias in terms of people who respond to that. It's a nationwide survey, so there may be regional differences. And as to how much this relates to our community and the people in Georgia, and especially those with lupus, in terms of their perceptions or their intentions at this point, we don't know. And it very may well mirror the rest of the United States, but I think there are some other reasons to think there may be some significant differences. So I will say that, we're going to learn more about this over time. The goal research group that I'm helping to lead at Emory, we have this very much in the forefront of our mind. We are sending a special goals survey out for those of you who are in our research project. You should be receiving an interim COVID-specific survey. And for all of these reasons, we would love for you to participate in that. You all have been more than generous with your time, but you will hear from us very soon in the next week or two. We have it already. We're just finalizing some things, and we would love your honest feedback. We're not looking to point to people or shame anyone for any of their perceptions, but we want to know what our community is feeling and what their concerns are, and if there is anything that we can help in terms of education and awareness. And so I will share a lot of what we're learning from that survey in this venue, and we can continue the discussion along those lines. Okay, I am going to switch now to talk about some information regarding these new COVID variants that are out there, especially this United Kingdom or UK variant that we're hearing about. It's caused a lot of alarm. But first, let me just kind of give some definitions to start. And one is, what's a mutation? A mutation is a change in the virus's DNA. And a variant is when there are multiple distinct mutations or changes in the DNA that really make it different. And so that it has a significant different characteristic that allows us to easily distinguish it from other viruses. And not only by the way it behaves, but we can sequence the genome. We could actually find the DNA fingerprint of these viruses, and we can see where they have changed. So, one question I received is, what are the possibilities of even more mutations of the virus? Viruses very commonly mutate and have variants. This is what happens all the time. It's a natural thing. And that's how viruses and bacteria and all organisms, in a way, that's the concept behind, broadly evolution, but more in terms of specifically just adaptation and survival. We very much expect to see mutations and variants. And we're not surprised at all of seeing mutations and variants in this coronavirus. In fact, there are multiple thousands of different mutations and variants, and that's not alarming. So I just want you to know that. And it's an amazing survival tactic. The more these viruses replicate. The more they infect other people, they survive, they replicate. Remember, things divide and replicate by dividing or replicating and dividing their DNA so that this copy can go to the new virus, and that's the blueprint to create the new virus and everything that goes with it. And but every time it makes that copy, there's an opportunity for things to change. And that's the system by which the virus long term survives. Because over time, we're making vaccines, things are happening. And when these mutations occur, there may be something that happens that allows that virus with the new mutation to survive better. And they will then replicate more because they're infecting people, and that particular DNA strand mutation will live much longer. And the viruses that don't have mutations that allow it to survive better will then be selected out, and they will not replicate and not infect other people and basically die out. So, and that's what bacteria do to survive and become adapted to certain antibiotics. You've heard of antibiotic resistant strains. So all of this is not new, and it shouldn't be alarming, and we totally expect it, and it's happening all the time, and there's nothing we can do about it. When do we care about these mutations and variants, especially as it relates to the COVID virus? Well, if there's something that changes, that increases its pathogenicity, meaning that it leads to more severe infection, we certainly care about that. We also care if something changes about the virus that allows it to spread more easily. And we certainly also care if some change allows it to escape the effectiveness of a vaccine. So this whole UK variant came out of the fact that not just the United Kingdom, but many countries actually have concerted efforts, including the US too. And we've known all along that these viruses would mutate, create variants. So the UK has a very strong consortium. They've put in significant resources to it. They've been sequencing the genome of the viruses that they've been seeing in the United Kingdom. And they were the first to isolate this variant, which is why it's called the UK variant. Doesn't mean that it necessarily started there, but it's certainly where it's taken a foothold, and it was discovered. I'm going to call it the UK variant, but you can see that there's a couple other names, these very scientific names based on different aspects of their structure and where the mutations occur in the genome sequence. But you can see over time how in the UK they picked up a dramatic increase, and especially in the past month or two. But the UK variant is, again, it was named because it was discovered and isolated and had a high rate of increase in the UK, but not surprisingly, it's been found throughout the world. And there's no question it's in more countries than what you're seeing in color here. It's just not been, identified. But it's clearly around, and it's going to spread. And as you all have heard, it's in the United States and several of the states, including Georgia. But again, it's clearly in multiple other states, and it will continue to circulate and spread. So why do we care about the UK variant? Well, it is increasing in frequency. Fortunately, it does not seem to lead to any more severe infection, but it is certainly because of the increase in frequency. It's the characteristic of the mutations and the overall variant here is that it's highly transmissible, even more so than the original strains that were out there in the early part of the pandemic. I've heard numbers like it's 60, 70%. And I've heard of other experts kind of trying to break that down. It's greater. So I don't really know how much greater, but it's certainly significantly greater, leading to, in large populations like the United Kingdom, um, big spikes in the total number of COVID cases. So you can argue, is it 10%, 20%? I mean, bottom line is it's more transmissible and it's leading to big spikes in large groups of people and populations and countries, and it's just spreading. It's also uh, associated with higher viral loads, meaning people that get infected with this new variant, if you were to look into the lungs and get a sense of the numbers of actual viruses that are there, there's a lot more viruses in infected people and in parts of infected people with this UK variant. And that is probably related to this transmissibility, because if you think about it, if there's a lot more viruses in the lungs, there's just a lot more to then be thrown out into the air when they cough or they breathe. And um, that just helps it to become more transmissible and infectious to others. There's a fair number of mutations associated with this variant. And obviously the thing that we, at the end of the day, thankfully it's not more severe in terms of infection, but is it going to, is the vaccine going to work? And it appears, thankfully, that the Pfizer BioNTech vaccine is effective against this variant. I think there still should be some more confirmatory data or studies that come out beyond the few. There's different ways of doing it, but all the early signs seem to indicate that the vaccine is effective against this variant, which is highly encouraging. So at this point, for those of you who are online, I'd like for you to do a quick poll. It's just the only one here. So the question is, which will lead to more deaths after 1 month? Assuming things like, for those of you who are sophisticated about this, the same reproduction rate, case fatality rate, basically what it is now. So assuming that we have a virus with the characteristic as it is now, not the UK variant, but the ones that are more predominant, which will lead to more deaths after 1 month? A COVID mutation that becomes 50% more deadly, or COVID mutation that becomes 50% more transmissible or easier to infect others? Okay, so it's about going back and forth. It's like 50-50. Right now it's like 15 people, like 56% for transmissible and 44% deadly. So pretty close. Let me go here. Well, if without the UK variant, or this new hypothetical variant, I'm sorry, if there were 10,000 active infections, we would expect 129 deaths a month. If we had a 50% increase in how deadly a new variant becomes, there would be 193 deaths. With a 50% increase in transmissibility, there'd be 978 deaths. So that's why the UK variant is such a big thing. Again, it's nice to be reassured that if you do get infected by it, it doesn't mean that you'll get necessarily more severe outcome. But if it remains the same as in terms of the outcome of the COVID virus that we're used to, the variants that we're used to, we know, as we're hearing about all the deaths and the hospitalizations, we know that a certain percentage of people will get severe disease, will die from it. So it's this power of compound interest. It's one virus affecting 2, 3 people. Each one of those 3 people infect another 3 people. Each one of those 3 infect another 3, and so on and so on. And so it's really higher rapid spread. And yes, the majority may not get severe disease, but the numbers are so great that even small percentages of deaths and severe disease translate to high numbers total. And that's what's overwhelming our healthcare system, because COVID is a highly transmissible infectious virus. And now we have a variant that's even greater than what we've seen before. So we need to break this cycle where transmission is infecting other people. Every time someone gets infected, that's more opportunity for the virus to replicate. And every time viruses replicate, variants occur, the DNA changes, things evolve, and there's a greater chance that we get a strain that's more difficult to treat. So that's why overall it's important to break that by all that we're been preaching about: masks, social distancing, hand washing, and now vaccination. And it's really all of those things that will really sort of slow this down and be able to keep this under control and for us to get back into the normal state of things. Just so that you're aware, all the labs and stuff are aware by now. There are some kits that are using assays that this new variant it's not being picked up in the right way. All I know is that Emory and Grady don't use any of these assays, so this is not an issue that I've had to deal with. I don't know how other systems throughout the state, if any of, like, what are the groups, organizations that are using these assays in particular. But I'm sure they're quickly adapting and changing to different things according to what we're discovering. This is a quick point about the US just lagging in terms of sequencing the coronavirus. We're at number 43. We have Britain here at number 8. They sequence a lot. They're in the top 10. I think the CDC is pushing to do a lot more. And that's why it's probably taken us a little longer to find the UK variant. But it's important to do these tests when you're fighting this type of battle. And again, it requires public health infrastructure to do it. And we need to really invest in that long term, obviously. So going into the questions that I've received, I've lumped all of these together because it really talks a lot about along the lines of the safety and efficacy, especially in people with lupus. So, and I will try to get to everyone and at least make a quick comment. Do you know the safety of either vaccines for lupus? And do you know if anyone with lupus who has received either of the vaccines? We don't know. As I mentioned last time, there are plans to start looking, now that these vaccines have been tested in the general population, where there are a lot of efforts in very specific populations. And we'll talk about in a question in a few slides from now about pregnancy, children, transplant patients, and now immunocompromised patients with lupus. So those results are not out yet. We don't know the safety in lupus. We do know that, generally speaking, most vaccines are quite safe in people with lupus. mRNA vaccines are new, but theoretically, the way they work, it really shouldn't be that much different in terms of our concerns. There are theoretical concerns still that it may ramp up the immune system and lead to a flare. It's much greater in other types of vaccines that, for example, there are certain vaccines that use an adjuvant. It's specifically designed to ramp up the immune system. And that's good in a vaccine because you want a good response to a vaccine so that you have a really strong memory to it. But that could be bad for lupus because it could ramp up the immune system in a bad way for a lupus flare. But an mRNA vaccine does not have that. There is reactogenicity that I've talked about in previous weeks, where you can have a mild to moderate reaction in the first couple of days that goes away completely. That shouldn't directly be related to a lupus flare, but these are very specific questions that we don't have exact answers for. We have theoreticals. So the vaccine obviously is out and available, and it will soon be available to broader groups, including high-risk groups, including immunocompromised patients, including those with lupus, which goes to the second question as well, and others. And so it really boils down to a lot of individual factors, some factors that we do know, others that are theoretical, like I'm mentioning, a lot of individual factors in terms of people's other risk issues, medications that they're taking. So we don't know, but it will be available to many of you out there. And I think it's going to be down to an individual decision until we have more and more data, which will come, but it may not come for many more months. So I'm going to have to hedge and continue to hedge for a while, that you're going to have to talk it over with your healthcare team, because there will be, all these questions are very specific. There are a lot of different variables. But I will say, generally speaking, I do agree with most that, I think theoretically, we should be fairly optimistic that most people with lupus should be able to take it fairly safely from what we generally understand about vaccines and about the mRNA vaccine that we have. I don't know anybody with lupus who's taken it yet. If you are, please let me know. It'd be great to share your experience. And we're getting that type of information in the goal survey as well. Have there been any specific studies involving lupus patients and COVID vaccine? I told you not yet, but there are going to be. And I talked about the main concerns for people with autoimmune conditions. Is it safe? We don't know yet. I think so, but in general, but we don't know. Should you get the vaccine? The other thing to think about in terms of individual issues is weighing the risks and benefits. We do know that certain things like obesity, heart disease, those are, and age, those are really major factors in terms of very poor outcomes if you were to get infected. And if you had lupus on top of that, that may be something that really tips in favor of a vaccine, even if we don't know exactly what happens. So again, you have to discuss this with your doctor and your healthcare team. Is there any evidence or concerns about exacerbating lupus? I talked about that. Antiphospholipid syndrome is interesting. Not everybody with lupus has it, but some people with lupus can have these antiphospholipid antibodies that lead to blood clots, very severe ones, recurrent miscarriages. And people with very sick COVID, many are found to have developed antiphospholipid antibodies and have very severe clotting. What that exactly means for people with lupus that have antiphospholipid antibodies, I don't know, but there are very interesting questions here, and we need to remain engaged as a community with these questions, and as a community with the research community as well, so that we can answer those questions. And I hope you will continue to partner with us as we continue a lot of that research. I have lupus, should I get the COVID-19 vaccine? Talk it over with your doctor. Daughter is 13 with lupus. The vaccine isn't available or approved yet for children. You're right, there is at least one active clinical trial, I think with the AstraZeneca vaccine, I forget, but it's at CHOA. They're actively recruiting in children. So you'll just have to wait and see. And specifically about your daughter who's having immunity issues with other vaccines, I'm not able to answer specific questions like that. Sorry. Once the vaccine becomes available, would I recommend them to people with lupus or lupus nephritis? I'm telling you, I have my personal approach, and I think it's a lot of individual discussion at this point. I can give you general comments, and most of the general comments are that we don't know. A lot of theoretical comments, as I mentioned, it probably is generally safe, but we just don't know. I put this one separately because to remind me about rituximab and also belimumab or Benlysta, or these are medications that suppress B cells, and B cells produce antibodies, and antibodies are what help with the vaccine response. So if you are on rituximab or belimumab, you will have some reduction of response to the COVID vaccine. So again, talk to your healthcare team and your rheumatologist in particular, especially with the vaccines being rolled out. If you are someone who is highly interested in getting it in the near future, but there's discussion about starting rituximab or belimumab, and maybe some other medications as well, you need to discuss that with your healthcare team, because ideally, especially with something like rituximab or Rituxan, you would want to get the vaccine several weeks before you start it. Now, if you're on it, then getting the vaccine, it won't be harmful necessarily, but it will certainly be less effective. Will it be less effective to the point where it's ineffective? We just don't know any of that yet. This is a question where it's just really individualized, and I'm unable to answer that, or able to answer that. Have the studies come to a halt since the production of the various vaccine surface? No. There's research studies going on, and it's ramping up in many ways, even in the vaccine area. I mentioned the Chinese vaccine that got approved. We need many more vaccines available, because we clearly are not close to meeting the needs, not only in this country, but worldwide. So the more options we have, the more availability of vaccines, regardless of the type and how we give it, as long as it's safe and reasonably effective, we need that. So there's a lot of research there, and there's a lot of research along so many other aspects now. What happens in people with lupus and other autoimmune diseases? What happens long term? Why do some people produce autoantibodies that we see in lupus when they get infected with COVID? There's so many interesting questions, important questions that we need to answer together. Do you think we're playing Russian roulette by encouraging individuals who are not represented in the studies to take the vaccine, such as pregnant women, transplant patients, asthma patients, and children? Well, I'm not sure of anybody who's encouraging vaccination in groups who are not specifically studied in the original studies, including every group that's listed here. And there are, like I said, certain clinical trials in some groups that are very active and should come up with results soon. Like, children, there's a great importance there, because we need children to go back to school safely, and it'd be great to have a safe vaccine for them. So everybody's eyeing to try to get the results back and safely before the start of next school year. So that's clearly, I think we're going to know one way or the other pretty soon here. And then all the other groups, we just don't know at this point. But we're learning more each and every week, and there are some groups that have more specific studies than other groups. But with each and every passing study, we do learn more about general information that would be helpful for other conditions. The pregnant women, I've heard from some experts that they feel very comfortable that pregnant women get it. Again, you should always go back and talk to your doctors about this. Pregnancy is important to think about because there is some data to show that people who are pregnant are at increased risk for having more severe disease and adverse outcomes from COVID. There are very few studies in pregnancy with the vaccines, but there is information from rats, pregnant rats, and there is no impact on those pregnancies or the babies, the rat babies. And the way that the mRNA vaccine works, as I mentioned in December, it stays in your body very short period of time, like a day. I mean, it's just a matter of hours, not a long period of time, and it doesn't go into the baby at all. So theoretically, it all seems very safe, but we don't know specifically. We don't have a study in pregnant people, so I'm not sure what the status of that is, but I do know that a lot of people feel comfortable in giving that, and given the risks of COVID in pregnancies, they're advising it, but you should talk to your doctor about that. What percentage of minorities were involved in the studies of the vaccine? So that's a good question. I had to look it up. This is the New England Journal article of the Pfizer vaccine, and you can see that there were a total of 37,000 people, half who got the vaccine, half with the placebo. And these are randomized. So, and there's so many people in these studies that you can see the randomization worked. Basically, half of the people were in every one of these categories were either in the placebo or the vaccine group. That's how randomization works over time. So basically 80% were white, 9.9 something percent were Black, 4 something percent Asian, and 28% were Hispanic. Looking at the Moderna vaccine, sorry, these numbers are even smaller. Couldn't figure out how to make it bigger without cutting some sections off, but 20% were Hispanic, 80% white, 10% Black, 4% Asian. So I hope that gives you some idea of the breakup. Is the vaccine really safe? Has there been enough studies done? We discussed this in the 2 town halls in December. I encourage you to go back and look at those videos for more detail, but I'll just review for many of you. This is what typically happens with vaccines. They take a decade or more, a couple decades at least, to go through the process. And whereas COVID only took less than a couple years, it truly is warp speed. But it wasn't because we cut corners on it. What happens normally, this is kind of a normal vaccine process. Vaccines, from what I have been told, do not make large amounts of money for pharmaceutical companies. Obviously, they have to make money, but compared to some of these other drugs that they have, it is not a blockbuster by any means. And it's a long and expensive process to develop vaccines. So because of the time and expense, you really need to kind of take it carefully, be conservative. So every step you see here doesn't overlap with the step before. So they finish a step and then they decide what the results are. Then they decide how then to plan for the next phase. Commit the funds. I mean, they have to find the money along the way. It's not like they have all the money up front. They have to build these things over time. So it's a very stepwise, careful process, risk benefit analysis, not only clinically safety wise, but also financially for these companies. But what Operation Warp Speed did was it did not cut any of those corners. Every one of those steps were taken in the order that it did. But what it allowed the companies to do, because billions of taxpayer dollars were committed ahead of time, so there was minimal financial risk to the companies, that they were allowed to then accelerate the process where when one process was going on, they were already planning on the second process, had that in place, had knew exactly what to do based on different outcomes of the step before, so that as soon as they finished the step before, they were on to the next step. And this was all funded, basically. And that really it's what led to this amazing progress, along with the scientific advances and the input of the entire world put together to confront this battle. So along those lines, it is safe. And just to remind you, what most people kind of think about or are concerned about with, it's reasonable, is really more what we call reactogenicity. This is the immune system being acted up in a way as a normal response to the vaccine. Most vaccines in most people, there'll be very minimal reactogenicity. There'll be some soreness. That's it. Maybe some very mild features of these other things. Truly medically important events that require either hospitalization or something more significant or as significant is extremely, extremely rare. So this reactogenicity is, I think, what has really led to kind of this myth about, I get the flu from the flu vaccine. It's really more this reaction. And I've talked about how the shingles vaccine has been well known to be a significant cause of this. And the mRNA vaccines like Pfizer and Moderna have some of this. It doesn't happen as often or as great as the shingles, but more so than the flu is the general consensus. And I just finished, I got my second Pfizer vaccine on Wednesday this past week. After the first one, I had a very little soreness. But after the second one, 24 hours after the second one, I felt like I had the flu. The soreness got worse. I had some achiness. I was just really fatigued. I had low-grade fever, chills, and I was pretty much out of commission. I wasn't on death's door, but I was decently sick. So I just ended up kind of sitting around, moping around. And it started around 2 or 3 in the afternoon. I went to bed around 10 o'clock at night, and I woke up the next day completely fine. And that's really what reactogenicity is that for people who have more of a severe reaction, it can be unpleasant. And I didn't get any work done, and thankfully I did not have to be in the hospital that day. But the other good thing about reactogenicity is that by definition, it goes away basically completely in a day or two at the most. And there has been no evidence for long-term effects from any vaccine. Of course, we don't have actual long-term data for these COVID vaccines, but there's no reason to think that it would be any different than all the other vaccines that have been around for many, many years, given to millions and millions of people throughout the world. And none of these conditions have been proven to be linked with any of the vaccines, despite some of these anti-vaccination movements that you've heard or seen. Please discuss the 2 types brands of the vaccine available. Is it better to take the Pfizer brand now or wait for the newer vaccines? Take what you can get as soon as you can get. Once they're out in the market, they're going to be proven safe and effective. You can argue, well, should I take the 78% effective X vaccine or this 90% Y vaccine? Well, if we were in a position where you can go into a a pharmacy and you can have a choice of the three, then we can talk. But we're not going to be in that situation. There are going to be multiple vaccines available, but in your area, it's going to be short supply. And when there is something out there that you are able to get, and you can get that reservation to get that vaccine, it doesn't matter what company it is, how it's given, or what the data is behind that. You should go get it. This is my last slide, just to remind you, I've shown this in the past. Vaccines will end this epidemic or pandemic if we can get enough immunity. It's clear that we cannot achieve this level of immunity in the world just by letting the vaccine go rampant, which it is, but it's causing havoc right now, and we're still not up to this, not even close. So the only way we'll get there is to vaccinate. And this is not to say that those people who are listening here with lupus, you should definitely get vaccinated to help meet this. There are a lot of individual reasons, including those who may not be comfortable or have very severe concerns about a reaction with lupus. But what I am talking about, though, is globally. And, I hope that you can help spread the word of some of the general positive and safe aspects of the vaccine for those of the family members or friends who that don't have the issues like lupus, who may be wondering whether they should get it or not. The more we can get people who would generally be able to safely get the vaccine, the closer we're going to get to the herd immunity that we'll need. And that serves us better as a whole, because the closer we will be to going back to normal back at that time. So there's a lot of reason to be hopeful, but only if we continue to wear masks, watch your distance, wash your hands, and we continue to have the vaccines rolled out to the people who are willing to get it, that it's safe and effective for, and we can get that out in a timely fashion in the US as well as the rest of the world. Let me see if I can answer some of these things really quickly, because I've gotten really longer than I want to. How do you prepare for COVID? Not sure what you mean by that question. What are the precautions for taking Symphony when you have lupus? A little too specific. We don't have the information. What's currently the best biologic medicine for lupus? Too broad, too individualized. I'm sorry, I can't answer those questions in this venue. You should talk it over with your doctor. Someone reports getting their first dose last week. No problem so far. Okay, so thank you, everyone. And please continue to go to the Lupus Foundation of America Georgia chapter website, and Terry and the team do a great job of procuring the resources that will help you to fill in the blanks and for your particular situation, along with information from your healthcare team. The National Lupus Foundation also has information that they're procuring and putting together. And please continue to send your questions. Our next town hall will continue to be every other week. So in 2 weeks from now, the Lord willing, I'll be with you. And until then, please be safe.